much for the kind introduction and also the kind invitation to be here. It's a true pleasure being here. One thing that I want to start with, prior to actually getting into the talk, is that you have to keep in mind this is not simply an issue for end-stage renal disease. It's not simply an issue for people who might choose to withhold dialysis and allow the natural process to unfold. We don't know the final form of the legislation right now. That'll come out within the next probably 2 weeks or so. We don't know if it's going to even meet the June 6th deadline. However, there is certainly a chance that it could include the stipulation that once you are diagnosed with an irremediable illness, if you say you are in an intolerable state of suffering and you have capacity, you can access this. So that could be when you're diagnosed at any point of the illness. That could be at a point prior to getting to end-stage renal disease where you have nausea and you don't like nausea and you're with full capacity and you choose to access this. So we need to broaden our thinking beyond simply end-stage renal disease or end stages of illness that may not only be that. That's the first pitch that I want to make for the relevance of a talk like this and the subsequent content. In terms of what I'm going to go through, I've got about 30 minutes. I do not plan to take the full 30 minutes. I'll aim to take maybe 20, 25 minutes or so. And I'm going to break it down into these three parts. First, background on some of the issues relevant to this whole discussion and debate. Then we'll look at the evolving process since Carter. I suspect several of you are familiar with some of these things, and I'll go over that relatively quickly. But I do think it's important to have some understanding of how we are at the point that we're at now, and the likely legal ramifications and others as things unfold. And for the last 10 minutes, I'm actually going to talk about the specific mental health and mental illness related issues, because those occasionally crop up in the discussions, but by and large, in the larger debate, they've actually been absent. People have tended to focus on the cases that certainly qualify for something like this, or certainly should not. But some of the in-between cases, I would say, haven't been necessarily considered in the same way. So that's the outline of the topic. So here's the debate. It's often presented as a debate between belief systems. I'm not sure if that's the case. You know, if you listen to Maureen Taylor, wife of our former Officer of Health, she will actually say that even in faith-based communities and religious communities, a lot of people support some form of physician-assisted dying, or MEID. Where the debate comes in is who should that apply to, under what circumstances, etc. So I actually don't know if it's debate about belief systems as much as some other things. But let's look at belief systems for a second. Shifting societal views. We know from the previous case that went to the Supreme Court that, you know, a decade, 2 decades ago, society in Canada would have never considered something like physician-assisted dying. It is something where societal views have changed and evolved to say that, okay, we actually think in certain situations maybe it's okay. But what about the meaning of suffering? One of the key concepts in this entire framework is intolerable suffering. What brought us all into medicine? Presumably, we see people who suffer. That's why we're here. Some belief systems actually are predicated on suffering. Look at Buddhism. You can't actually think about Buddhism without thinking about the meaning of suffering. And so there can be certain issues in belief systems that are at odds here. This thing about individuals versus group decision making, I'm not going to get into that in detail, but I think you probably have a sense of what I'm talking about. Right now, the entire framework is based on very individual decision making. We know that decisions about meaning and purpose in life, and the point of living and role in society and our own individual roles, those aren't predicated just on one person's individual internal decision making process. That is actually often a group decision in some cultures. And what about the culture of medicine? So here's where I'm going to get to a different suggestion, that it's not necessarily about belief systems, but actually about conflict of principles or concepts even within belief systems. Title of the talk, of my portion of it, Do No Harm, Help Me Die. There's a conflict right there. And that conflict is taken out of our own code, not necessarily the Hippocratic Oath. You know, the words do no harm don't actually appear in the Hippocratic Oath. But there are things that allude to that, and certainly it's a tenet that we try to follow. This is what appears in the Hippocratic Oath. With regard to healing the sick, I'll devise and order the best diet according to my judgment. Take care of them that they suffer no hurt or damage, nor shall any man's entreaty prevail upon me to administer poison to anyone. So within our own belief system, some people point at this and say, what are you talking about? How can we as physicians help someone die? Are we not administering a poison to them? Other people say, but wait a minute. If we are not helping them at their last stages of life in a state of intolerable suffering, are we not allowing them to continue to suffer unnecessary hurt or damage? It's not necessarily about the belief system. Even within our own belief system, there are inherent conflicts of principles. This is actually a dean from Tufts in the 60s, Lasagna. I love that name. He did a modernized version of the Hippocratic Oath, which a lot of North American schools use now. And it's interesting because this actually gets a little bit to some of the issues we're talking about now. For the benefit of the sick, I will apply all measures, avoiding twin traps of overtreatment and therapeutic nihilism. So you can see how we, within our own system of medicine, need to struggle with these conflicts. And the reason I'm presenting it this way is that if it becomes about belief systems, people get entrenched in their views. And they shut down and they tend not to listen. I think that everyone who has a strong view in this, they're coming at it from a good perspective, but they might be coming at it from a different perspective than someone who vehemently disagrees with you. So I'm glad for the no fisticuffs and the no hesitation. So let's look at some of the potential conflicts. Autonomy versus beneficence, kind of self-evident what I mean by that. We want to take care of people, but what if what they want to do is not, in our opinion, in their best interest? Subjective versus eternal reality, we'll talk more about that later. But the idea of the person having an assessment versus whatever we consider outside them, whether it's a medical system or science having an assessment. Patient rights versus provider rights. This touches on the whole issue of conscientious objection, for example. How can you tease that apart from access? Because all these things are interrelated. If there are so many people that conscientiously object that patients can't get access to something that we think they have a right to, that could be problematic. How do you balance those things? And I would actually say this other one. This comes up in public discourse all the time. Suicide prevention versus assisted dying. Hey doc, you as a psychiatrist, haven't you talked about suicide reduction strategies for, goodness knows how long? How is this different? Well, it is different. It actually is. But there are nuances that need to be teased apart. And on the surface, people will often jump to the conclusion that final common endpoint is death. These things must be the same. And I do think that there's a difference. Some cross-cultural studies actually help illustrate that for us. If you look at cultures where people are designated as committing suicide, sometimes you find that a bunch of them have had what we would term here as mental illnesses, but many have not. And if you separate those groups, the people with mental illness are ones who go through different courses of illness and suffering. The other group, that group is often a group that wants death. The other group has gone through things like divorce, they've lost their jobs, they've lost their social situation. What they want is a change in life. So I do think that there's a difference between why somebody wants death in terms of suicide versus the current assisted dying. So those are some potential conflicts. Now, let's switch a bit to the evolving process. I'm going to go over this very quickly, but you know why we're here having this discussion. It's from this Supreme Court ruling from 2015 February, the Carter v. Canada ruling. And in this ruling, what the court decided was that the prohibition against physician-assisted dying in Canada infringed on the Section 7 of our Charter of Rights and Freedoms. And I'll elaborate on that in a moment about why they felt that. But that's what they ruled, that the prohibition against PAD, as it was called at that time, violated Charter 7. And the key concepts of this ruling, again, we'll talk about more about this in the mental illness piece. The key concepts are that if someone has a grievous and irremediable medical condition, they have intolerable and enduring suffering, and they are competent. And Carter actually only spoke about adults, so in that case it was they are competent adults. Then they should be able to access physician-assisted dying. What was the violation? So I'm not sure how familiar people are with constitutional law here, but Charter of Rights and Freedom, Section 7 speaks to the right to life, liberty, and security of the person. How does a prohibition against physician-assisted dying violate the right to life? It's interesting because they have a valid point. What they said was that in the cases before them, which were essentially ones of neurodegenerative illness, so ALS and spinal stenosis were the ones that they were considering. What they said was that the person will get to a point where they are so physically incapacitated that they cannot act to take their life. They lose agency, as we might say. And in that state, if they're in a state of intolerable suffering, unless we help them in medicine to end their life, they might choose to end their life before getting to a state of intolerable suffering while they still can. So in other words, I'm diagnosed with this illness, I know where it's going to lead, I know I'm going to get to a point where I can't act myself because I'll be physically incapacitated. Before I get there, I'm going to kill myself while I can. That period of life that is lost, the court found, is a violation of the Charter of the Right to Life. Because you are now making me kill myself, end my life, before I would otherwise do it, even when I might not be in a state of intolerable suffering. So that was the violation to right to life. Won't go over in detail the other two, but they're similar. Right to liberty, individuals' response to the condition is a matter critical to their dignity and autonomy, and the prohibition denies them the right to make decisions concerning their integrity, and thus trenches on their liberty, and similarly for security. Leaving them to endure intolerable suffering, it impinges on the security of the person. This was the violation. They actually didn't rule on the other violation, or on the other section they were asked to rule on, because they said, if this is violated, we don't even need to rule on the other section. So keep that in mind as we're going forward a bit. What's then happened since then? That was February 2015. There was a one-year timeline that the government had, February 6, 2016, to then implement legislation that abided by kind of the ruling. And a few things happened in that time. There was an external committee struck up, and provincial territorial groups separately worked on that. And then more recently, after the election, there was a joint Senate Commons committee that looked at the issue of physician-assisted dying. They've changed the phraseology now to medical assistance in dying, so now you'll see MAID instead of PAC. But it refers to the same thing. You know we're past February 6th, 2016, and there's nothing in place. Reason for that is the government, when it was elected, asked for an extension. I think they asked for 1 year and they were granted 4 months, which brings us up to about 2 weeks. So that's what's happened so far in terms of the timelines and where we're at. And now, for the last part, I actually want to talk, because we're going to talk about cases afterwards. I know James will present some stuff and there'll be discussion about potential kind of cases clinically that we might be looking at. But I do want to spend about 10 minutes talking about the issue of mental illness in this context. Because, again, that hasn't really been thought about up until around October, November. The whole issue of how that might be dealt with was not a consideration in any of this framework. The Supreme Court acknowledged that psychological suffering must be considered. But the idea of whether a primary mental illness should be able to, quote unquote, access this or not, that was sort of left nebulous. And up until, I'd say, late last year, the issues about how this might play out weren't openly considered. So what, if anything, is different in mental illness? I'm going to toss it out, and this isn't just for the psychiatrists or the non-psychiatrists, audience in general. Do people think that there is any difference with mental illness in terms of somebody applying for MAID or PAD for a primary mental illness absent any other medical disorder? So usually when I ask that, I'm not going to ask people to put up their hands because people have their own views and stuff, but usually when I ask that, there's a fair bit of nodding in the room, some not nodding, some degree of discomfort about why are you asking us this? Aren't you the one giving the talk? But in terms of polling, when we actually look at this, what I can tell you is that the majority in any group that I've looked at that's polled, whether it's medical professionals or the lay public, they actually do feel there's a difference, but they can't necessarily articulate what that is. And it is a challenge because, aren't we the guys who for years have said, hey, don't discriminate against the mentally ill, don't discriminate against all of this, and everything is, you've got to have equity on everything. Absolutely, we have. But you know what? Equity does not mean everything is the same. Equity means that things are considered fairly and impartially for what they are. And in fact, equity does mean that if things are different, they're treated differently. So it's not about being the same, it's about articulating whether things are different or not. Now, none of this is to suggest that things are different. What I'm going to do in the next 10 minutes is go through some stuff to suggest to you that actually I do think some things are different in terms of how they need to be considered. And then we've got to struggle with how we consider them. But keep this in mind. Equity does not mean everything is the same. So it isn't necessarily discrimination to say, how do we consider something in a broader framework? So let's look at mental illness then. Sessions have an infringement. They may or may not hold for mental illness. We actually don't know. I would say people would be hard-pressed to say that they hold for the infringement on right to life. Very few mental illnesses lead to the point of someone being so incapacitated that they lose agency to act. They may lose capacity to act or they may not, but they don't necessarily lose agency to act and actually necessarily take their lives. There are some exceptions. I mean, dementia, I think you could say, whether it's a psychiatric or neurological illness, in that you may well lose agency itself. But in most cases of depression, you wouldn't. In most cases, which is actually what PAD is typically most commonly applied for in places like that. So whether the infringements are the same, again, we don't know, that's untested. But let's shift from the legal thing to what we know better, which is the clinical stuff and the medical stuff. Key concepts. The subjective versus external assessment, capacity, irremediability, and I'm going to end on access, which is not something that was actually part of the framework in the Supreme Court and now has become, part of the discussion in terms of what we need to be looking at in this access. Okay, subjective. Supreme Court was crystal clear. The suffering in a PAD or MEID framework, that is subjective. So if I say to you, my suffering is intolerable, it is intolerable. And you as my doctor, you as my nurse, you as my partner cannot tell me otherwise. That's my judgment. They were very clear on that. The acceptability of treatments, that is, I would say that's largely subjective, but there is a gray zone here because what the Supreme Court said was that treatments must be acceptable to the person, essentially. But everything in the Supreme Court ruling is predicated on autonomous and capable people, capable adults in the Supreme Court ruling, actually. We know in psychiatry and mental health that you can get and will get and do get in many provinces, depending on mental health legislation, patients who may actually not have capacity for decision making, but they still don't get treatment. The only time that we can actually have people, for example, admitted and potentially get treatment if they don't want it, is in many provinces if they're a risk to themselves or others. And then they can be certified and brought in. But you certainly do have people who may well lack capacity, not want to take medications because of either delusional beliefs or others, and they're not harmful to themselves or others. You don't have much that you can actually do, and they may then continue without treatment. So I'd ask you as a question, which I don't have an answer to. In that case, if somebody lacking capacity declines treatment because I think you're poisoning my pills, I don't want to take them because I think that. And that then makes me irremediable. And I properly judge that if I'm irremediable, I'm suffering. Should I be able to access this? I don't know the answer to it. But what I would suggest to you is the Supreme Court didn't look at that up. So acceptability of treatment is largely subjective, but there is some other element that I think we may need to consider with mental illness sometimes. So what about capacity?
So you don't have to have the loss of agency, as you said. That person can still potentially do what they want to do.
They can. I mean, by agency, I mean that if somebody wants to do something, are they able to?
Right.
Separate from capacity.
Right.
Right? So if somebody doesn't want
But
treatment,
not required for the main.
Right.
It's not, if you have agency, you can still apply for the main. Or you can say, but I don't.
oh
I
yeah,
don't
of
follow,
course.
right?
Yeah. But I mean, the question is that in the capacity assessment, would that mean, because let's say that I correctly can say that now I'm irremediable.
Right.
If I don't have treatment, I'm irremediable. And that's actually correct assessment. I have capacity for that decision. Capacity is treatment or is decision specific. So what if you lack capacity for the first decision that leads to the point of the second decision where you could access this? Again, that's not an answered question right now, is what I'm suggesting. In terms of capacity, I won't go through all of this. I mean, people know how to do capacity assessments, but these are the key things we look at in terms of capacity. What we do know is that capacity, as I was saying, is specific to the decision that you're making. So I could have capacity for one decision and lack capacity for another. So let me ask you this. You come in with a stomach ache, and I say, here, take this pill, it'll help you for your ulcer. What goes through your mind in making that decision? Just shout out a couple of things. It's always the same, similar kind of stuff.
I don't want to take more pills.
I don't want to take more pills.
Side effects.
Side effects, tolerability, is it going to make me
Trust.
Trust, is it going to work, is it, etc. So all of that stuff plays through your mind. What about this? Do I want to live or die? You think about different things, right? You think about things on various levels. You also think about, well, again, what's my place in the world? What's, like all sorts of things. My point is, it's a different decision. So capacity assessments, again, as we know, are not universal for capacity. But let's look at what might affect this. Do I want to live or die? With mental illness. And again, I'm going to come back to the mental illness of depression, because that is the one that we know from studies where they have PAD for mental illness. That's the one that we know is most predominantly applied under. So this typical cognitive triad, I suck, the world sucks, and the future is going to suck, right? We know that people change how they think with depression. We know that there's a loss of cognitive flexibility. There can be a loss of future-oriented thought. There is actually work being done in multiple centers, one of which is in Ottawa, where they actually think that there may be correlations with some brain functional changes in specific areas that link to a loss of ability to see the future, or to see that there is any future. Things like selective negative ruminations and positive ones being discounted. So all of this stuff comes into play in depression, and I would just ask you to consider, how do you tease this apart from somebody's autonomous decision-making process, absent these kinds of distortions in depression? I'm not saying it cannot be done, I'm just saying that it is very challenging and not something that was considered in the Supreme Court group, again, which is predicated on full capacity. Remediability, here's another very tricky one, and actually, in many ways, huge amounts come down to this for mental illness in a way that is different from a lot of other medical illnesses. Because remediability is not the same as irremediability. Remediability means, what can we try to fix? Irremediability means we can't fix anything or we can't fix it. It's kind of more of an on or off. Is that subjective or external? Well, we know that in depression, I might be convinced that, no, this isn't going to work for me, even though 3 years ago when I was depressed, it worked for me and I stayed well for 2.5 years. Right? We know that that kind of thing can happen. So whether the judgment of remediability is subjective or external, naturally there needs to be some external element to a judgment of remediability, because that relies on also science and prognosis, etc., etc. But our assessment, as I said, is what is remediable, and it's very different from when it is irremediable, especially in mental illness. We do not look just at physical symptoms, right? I mean, Ralph, you talked about that commonality of losing loved ones, right? So we know in most mental illness, things like social isolation, poverty, all sorts of psychosocial stressors make the suffering from the illness worse. So when do we as a society say that that is irremediable? And all of that gets bundled up to irremediability of mental illness. We're being asked to do something very different now that we have not done anywhere. I would actually say to you, has not been done anywhere in the world, because there are not standards for this, for saying when is, or when are most mental illnesses irremediable. What we're being asked to do is going from this kind of analog graded scale of saying, okay, I can fix this a little bit, maybe we can increase your social engagement, maybe we can reduce your symptoms, decrease the side effects, do other things. I'm being asked to go from this graded scale of various things in an analog way that we can try to improve to a dichotomous on or off decision of now it's irremediable. I don't know how to do that. I can tell you that when I said that as president of the Canadian Psychiatric Association, I hesitated to say it because I thought, geez, maybe I shouldn't be in this role if I'm the only one in the room who doesn't know how to do that for mental illness. And what I can tell you is, I don't think anyone knows how to do that for mental illness. No one on the board knows how to do that. No one in other countries really knows how to do that in terms of the standard of care. The other thing you'll notice is, when you translate frameworks like this, if you pick this up, the times are different. We're going from like 10:08 to 10:28. So sometimes when you translate frameworks, something is lost in the translation. So I'm going to wrap up very soon, but last point I want to make on remediability is that capacity assessments are sort of similar. We're asked to go in and weigh multiple factors and say, does someone have capacity for this or not? That's also dichotomous, on or off. But those are point-in-time assessments with established standards. Remediability is also predictive of the future and what will happen. That opens up all sorts of things, especially in mental illnesses, where we often don't know when to say nothing further. Last point I'll make on this is access. That with mental illness, Mental Health Commission tells us that like 1 in 3 Canadians who needs help for mental illness actually gets it. It's even worse for children, maybe 1 in 4. So you certainly would not want it to be something where applications for MAID come in as a proxy for lack of access and lack of having actually been able to get some help or remediation. Now, what has happened with these things now, and this will be the last about 4 minutes or so. So where are these things now? The Joint Senate Commons Committee, they actually have brought in the concept of essentially access. I won't read this in detail, but they are talking about needing to ensure appropriate mental health supports and services in place for individuals requesting medical assistance in time, which is, I think that's actually great to start to get to a discussion that you can't have a discussion about PAD or MAID without a discussion of access. Both are kind of necessary. In terms of irremediability, they actually did appreciate that irremediability, especially in mental illness, is complex and might not be as straightforward as irremediability in some illnesses like ALS, for example. They did suggest, though, that individuals not be excluded from eligibility based on the fact that they have a psychiatric condition. So that was the Senate report from around February. Part of what also happened around the same time was that a report in JAMA Psychiatry came out actually it was before this, I think, maybe online, but anyways, earlier this year. And it reviewed the cases in the Netherlands that had applied for physician-assisted death on grounds of primary mental illness. And there were 66 cases over the time period they looked at. And I won't read through all of this, but the things I'll point out is that the majority were, again, for depression. That's not a surprise. The majority also did have social isolation and loneliness. And again, when you're thinking about when do we say something is irremediable, I mean, should we be as a society trying to help this maybe in a different, I don't know. But it raised some concerns because of some of the unresolved psychosocial stressors that were contributing to suffering. And also because of some of the inconsistencies of application of processes. In just about 1 in 10 or a bit more, there was no independent psychiatric assessment, meaning that although there were multiple physicians involved in consultations throughout, even in cases of primary mental illness, no psychiatrist was actually involved in that application assessment in 11%. And in nearly 1 in 4, there was discrepant recommendations or disagreement amongst consultants. So again, this is just introducing a cautionary note. Don't have an answer for you. But what I will say is that in April, the Canadian Psychiatric Association, we actually came out and we said, as a formal policy, that there is no established standard of care in Canada, or as far as we know of in the world, for defining the threshold when typical psychiatric conditions should be considered irremediable. The draft Bill C-14 that came out, you know that then suggested that mental illness as a primary sole underlying request condition, that needs to be studied further. They also had some other things which were not directly related to mental illness, but if you think about it, they would separate mental illness out. The main one being natural death has become reasonably foreseeable. And as you know, this has come under a lot of fire because the Supreme Court decision didn't talk about it needing to be terminal, et cetera, et cetera. So we really don't know where things are going to settle right now. And the last thing I will leave you with is this, because this is from last week. The Alberta Court of Appeal ruling from last week, which was for a case of conversion disorder, psychiatric diagnosis in the DSM. They granted an exception to allow physician-assisted death in this case. And so there's a lot of kind of buzz about, well, this means that you have to have mental illness as a primary request allowed for, et cetera, et cetera. A couple of things about this case. Firstly, for those of you who know what conversion disorder is, which we know in parenthesis in DSM-5 called functional neurological symptom disorder, I think it is, or something like that. Basically, it's a disorder where you have unexplained physical symptoms. If you read through the actual ruling, you see that it is very clear that the court talks about the physical suffering that the person has from their spasms, from their muscular spasms. It keeps their eyes shut so they're essentially blind. They've got various other symptoms they need to be carried around. They talk about the physical symptoms. Essentially, they say something along the lines of, notwithstanding the fact that this is a psychiatric diagnosis, we think that the quality of life, we agree that quality of life is non-existent and they should get the exemption. They specifically say that the patient did not have depression and had full capacity. They specifically say that this is not something, or not this particular ruling, but they're saying any exemption in this case is being considered on an individual basis. And it is the opposite of precedential, meaning this is not something that is meant to set a precedent. So I would suggest that if something like that is setting a precedent for people with depression, it's not quite what the ruling was about. The last point I'm going to make is that the psychiatrists involved in the case, there were 3 physicians who actually provided evidence or testimony or opined in the case. One of whom was a psychiatrist. When you actually read through it, you see that the psychiatrist didn't see the patient. They did not examine the patient. They reviewed the medical files, and certainly you can glean a lot from doing that. But maybe you can glean remediability or irremediability if you know what that means, despite we don't have standards for it in psychiatry right now. I think it would be difficult to glean capacity from a medical chart review, and that's also part of what was done. So there are some issues with this that before people jump on this as saying, well, this therefore means that in June of this year, you should be able to apply for MAID for depression alone, introducing some caveats. And that's where I'm going to wrap up. So thank you very much. There's a big